Good afternoon, everybody. My name is Simon Claridge and I am the CEO at Manga. It's my absolute pleasure to welcome you all here this morning to our Falls webinar. As I'm sure many of you are aware, Manga pride ourselves on being specialists in post-fall management, and we've got ongoing projects that are not only supporting clinical evidence, but also looking at health economic data with regards to making savings to the NHS and organisations for picking up fallers. So leading the webinar and presentation this morning will be Adam Ferry. Adam is an OT and is a director of the OT service. He's going to be supported during the question and answer session by Kate Sheehan. Kate is also an OT and part of the OT service, and they're going to answer all of the clinical questions via the messaging facility. So please do feel free to send your messages across using that facility. And then we have a team here at Manga that are going to answer any product related questions. The webinar is going to last for about 45 minutes. So without any further ado, I'm going to hand over to Adam Ferry now. I'll hand over to you, Adam.
Thanks, Simon. I hope everyone can see and hear me okay. Obviously, there's no point in me asking whether you can, because I can't see you. But just for your reassurance, if you are having any audio or technical problems, everybody who's registered with the webinar will be sent the link to the recorded live event. So hopefully you'll be able to watch it back at your leisure, and that'll give you access to the slides as well. So hopefully if you are having any issues, that should resolve that for you. Simon, thank you for the introduction. Like Simon says, I'm Adam Ferry. I'm a director of the OT service and an occupational therapist. I worked in the NHS for a number of years, about 12 or 13 years, before moving full-time into the private sector, and have worked within Falls services, supported Falls services as an occupational therapist link. And my background is predominantly around neurological and elderly rehab. So my work experience in Falls services qualifies me, I think, to be able to present this for you. So what are we going to look at today? We're going to review risk factors of a fall. We're going to consider environmental and functional risk reduction. We're going to define and distinguish post-fall lie by duration, and that links to the reflection on the impact of a long lie and delayed initial recovery. And we'll look at the definitions of those two things, just in case you're not familiar with what they are and their differences. And we're going to establish some interventions to minimise risk to long-term health and well-being, both in falls prevention and post-fall management. Now, one of the challenges of doing these webinars is that they're fantastic and that they can reach such a wide audience. But if I was doing this face-to-face, I would use the slides as an aid memoir, really, and try and engage from the audience what information they wanted to hear or what they were the most interested in. On a webinar, you have to trust that the content is what people want to hear. So there will be some content in here that is a refresher, and that's absolutely fine. Every so often we need just to refresh our information and our knowledge banks. But hopefully there'll be some things in the content, particularly around post-fall intervention, that both pose reflections, so allow you to reflect on what you do or don't do, and provide some challenges or food for thought. That's the idea. So the first thing I'm going to show is just the definition of a fall, but actually how defining a fall can also be a challenge. So the first definition I've put up is the World Health Organization's there, which is an event which results in a person coming to rest inadvertently on the ground or floor or other lower level with or without the loss of consciousness. Now, the reason I've put that up initially, I'm sure everybody on this webinar is aware of how they would define a fall, but I just want to really briefly, because of my experiences in the NHS and local authority, just make quick reference to the fact that I think there's a big challenge, or there always seemed to be a big challenge, where figures across local authorities and hospital establishments were compared and contrasted. I know a lot of NHS targets and some funding streams were around the reduction of inpatient falls. But trusts and local authorities seem to use different definitions of falls, and I'm not going to say they used them to their own advantage, but it made it very difficult to make a direct comparison. And that's highlighted when you look at another definition there, which the first bit seems very similar, inadvertently coming to rest on the ground at other lower level. But this one from Carter specifically says without loss of consciousness. and other than as a consequence of sudden onset of paralysis, epileptic seizure, excess alcohol intake, or overwhelming external force. So we're using this definition. A fall wouldn't cover somebody who lost consciousness, ended up on the floor or lower level, had a stroke and ended up on the floor, seizure on the floor, or had a bit too much to drink and ended up on the floor, or indeed was pushed. Now, for us, I guess that doesn't really matter an awful lot, in that we don't, regardless of the definition of fall, we make an independent risk assessment, and regardless of what caused the person to end up on the floor, that form helps us formulate part of the risk assessment strategy. But it is worth understanding. So, and this is the bit where it might seem like a bit of a refresher. What are the risks? What are the falls risks? What do we see commonly within our practice? And they're generally categorized into 3 different categories. That's intrinsic, extrinsic, and behavioral risks categories. Intrinsic is relating to the person, as you'd expect. Extrinsic is relating to the environment, and behavioral is relating to choices or habits. So we'll look at them in a little more detail. So intrinsic risk factors would include impaired balance and gait, restricted mobility, perhaps past medical history, diagnoses such as Parkinson's, stroke, arthritis, cardiac abnormalities that cause symptoms such as postural hypertension or syncope. Medications, in particular, where there's so nice guidance suggests 4 or more medications, acute illness, dizziness, reduced muscle strength, foot problems. Foot problems is a really interesting one in my experience. We seem to, or there are times where we might brush over what we consider to be standard issues around the foot, so things like bunions, corns, and think that by foot problems it means something more complex in terms of the structure of the foot. But actually with foot problems, it'll just be anything that causes a change in gait or balance, and in some cases probably due to pain, and pain is there on the list as well. Impaired vision, that's a really important one, and we'll come on to that a little bit later. Extrinsic risk factors would include things like stairs and steps, clutter, or any other tripping hazards, floor coverings. So how often do we tell people to move rugs, fasten down loose carpets? Poor lighting, glare, shadows that are caused by lighting being in places that we wouldn't necessarily recommend. Low furniture, which inhibits a safe and independent stand in particular. Access, egress, uneven ground, inappropriate walking aids. So by inappropriate walking aids, it means, and I'll come on to this a little bit more on behavioural. So inappropriate walking aids, something that's either been prescribed and isn't right for the person, or something that was prescribed and it was absolutely the right thing for that person, but over a period of time, the person themselves, so the intrinsic factors have changed, and that walking aid is no longer appropriate. And a very common one there at the end, pets. I've seen lots of people who've tripped over cats and dogs and the like. Behavioural risk factors. So this is around choices or routines or habits. So using the example of that, the walking aid there, or any other assistive device, it's the inappropriate use of. And again, I'm sure we've all been in a situation where we've recommended something and provided something that's been absolutely the right thing for that person, and we've gone back a week or so later, or however long later, and they're just not using it in the way that was demonstrated and handed over. So it's not the equipment there that's causing the problem. It isn't an extrinsic risk factor. It's behavioural. It's something that's being used incorrectly. Footwear choices, so people using open-toed or open-backed sandals, flip-flops, slippers, shoes that are just the wrong size, and then wondering why they trip over threshes and things. Alcohol intake, limited physical activity or exercise, so that then leads to an intrinsic factor. So somebody, and we'll talk about this a lot more soon, somebody who has an anxiety of falling or is fearful of it, then chooses to limit their physical activity as a result. That limiting of activity is behavioural. The intrinsic effect of that is reduced muscle strength. Now, I don't know about anybody else, but certainly the OTs on this webinar, is that language in terms of intrinsic, extrinsic and behavioural doesn't necessarily hit home with me. I feel like the language isn't occupation focused. For some people, it absolutely will be, but for others, it won't. What I've tried to do there is demonstrate how I use that information to formulate part of my fall reduction risk assessment. And I've used what OTs will probably be very familiar with: person, environment, and occupation. PEO model. Others might know that as PET, person, environment, and task. It doesn't really matter what professional background you're coming from or what your role is. The terms person, environment, and occupation, they can be anything, whatever fits within your role, that's absolutely fine. But I'm an occupational therapist and I'm familiar with PEO, so I tend to put the information into those brackets. So you can see there some of the information that we've already discussed around risks, I've put into the relevant boxes there. With an optimal risk level in the middle. So what I'm looking to do is create interventions on those risks to reduce the risks. So when it overlaps, we're creating the least possible risk. And I've picked out a few things there that I might then focus on. So lighting on the left-hand side of that slide there. Within lighting, I might be looking at, is there good natural light coming into a room or to a space? There's lots of research and evidence about natural lighting and falls reduction. And there's a case study around DFG being used for dormer window to allow light to come into a kitchen, where actually the original request was for spot lighting. It's a really interesting case. So I might be looking at lighting there. If the environment's quite dark, is there any way of allowing more natural light to come into the space? Can I look at task lighting? So by task lighting, I mean lighting the object and the space that the task is taking place in with a general low-level light, if that's what that person needs. Visual impairments, that sometimes links to the lighting. Visual impairment, I might be looking at colour contrast, particularly with floor and walls. Does the person have any kind of proprioceptive deficits, or does their visual impairment inhibit on occasion their ability to see where floor space or where objects start and end? And I might use things like I say, colour contrast for that. So I'll look at light reflective values and make sure that walls, floors, etc. are contrasting enough to allow that space to be clearly highlighted and thus reducing the risk of falls. That's certainly one of the things we did within a inpatient audit when I was doing some work for the falls team there. We did a full audit of the wards, every single ward in the trust, and looked at where the hotspots for falls were, made recommendations about floor colouring, wall colouring, lighting, toilet seat colours and placements to make sure that the environments were as safe as possible for that patient group. The person within this case might be on a number of medications, so I've put the arrow there for medication. They might be on 4 or more cardiac medications, and that might flag an intervention. Fatigue, there I might be looking at either a compensatory approach with equipment to manage the levels of fatigue. I might be grading the activity, or I might be using a rehabilitative approach to build up the person's level of energy and therefore exercise tolerance. Outdoor environment, the bottom left, and that's one that we're probably quite familiar with, or certainly those of us who deal with adaptations, and we might be looking at step alterations, ramping, grab rails, access, egress, and how somebody gets the bins out, when often we're allowed to adapt, certainly in statutory services, we're allowed to adapt one access or egress. And one of the really interesting ones for me is within occupation. I've highlighted what is the purpose of the task and why is this meaningful. The reason I've highlighted that one is because within my falls assessments, and actually just my holistic occupational therapy assessments generally, I often get into a discussion about the use of the stairs. And it's really interesting in that in domestic settings, in somebody's own home, 10% of falls that occur happen on the stairs. And that's quite disproportionate if you think that we spend nowhere near 10% of our day on the stairs. The conversation I often have with people is that they feel like they want to continue to do the stairs, even though they're constituting a high risk because of the exercise that it gives them. And we have a conversation then about actually what's more important. Is it the task that they're going up or down the stairs to complete? That's the purposeful or meaningful bit of the task, or is it actually the walking up and down? And invariably, it's the task that they're going to complete. So they want to be able to go upstairs to get to bed, to sleep next to their partner, or to get to the bathroom to access the bath or the shower. The stairs themselves are a means to that end. And once we build in some exercise awareness into normal everyday activities of daily living, the person can then see that actually they don't need to be able to do the stairs or to walk up and down them. And it helps us make some suggestions around adaptations to that regard. But it's really important for us to know why people complete tasks, not just how, because if things are really meaningful to them, then adapting them or changing the task itself becomes a lot harder. And actually, it's the environment around the task that we need to look at. And all of those things that we've talked about fit in with a nice guideline. So a nice say that a multifactorial risk assessment is an identification of falls history. It's an assessment of gait, balance and mobility and muscle weakness. It's an assessment of osteoporosis risk. It's an assessment of the older person's perceived functional ability and fear relating to falling. It's an assessment of visual impairment. It's an assessment of cognitive impairment and neurological examination. It's an assessment of urinary incontinence and home hazards, and a cardiovascular examination and medication review. So I jump back a couple of slides. So this is the multifactorial risk assessment. It's actually all of that is covered or can be covered within that holistic assessment tool, which is how I tend to put things together, particularly if I feel like they're getting a little more complex. And nice when it talks about multifactorial interventions, it then refers to strength and balance training, home hazard assessment and intervention, visual assessment and appropriate referral to optician services if required, and medication review with modification and withdrawal. And all those factors are included within that. So we've got an assessment tool, we've got then something that leads us from assessment to intervention. So how can we deal with those specific risks, which leads us to the optimal risk level. And that's supported by the nice guidance there. But the reality is that despite everything we do, we could have the best risk assessment in the world to reduce falls. The reality is that we have to accept that people will still fall. So we're reducing the risk, but certainly as occupational therapists, our role is to maximise independence and engagement and activity, and that comes with inherent risks. So our only way of stopping somebody from falling or completely getting rid of the risk is to say, sit there and don't move, and everything will be brought to you. But occupational therapists, and not just occupational therapists, I'm just using occupational therapy language, that maximising of independence and engagement and activity comes with risks. So we have to accept that regardless of what we put in place, people will still fall. And that shows in the reality that 1/3 of people over 65 fall at least once a year. That increases to half of people over 80. Injury or ill health following a fall is the most common cause of death in over 65s. And the reason I've said injury or ill health is because that leads us on to where we're going to go next. Actually, people often, I often feel like professionally anyway, people are more concerned with the injury than the ill health. You know, what will the impact of the fall, the actual physical impact will create? Actually, the ill health following a fall is far more prevalent and debilitating. And falls account for approximately 10 to 25% of ambulance call-outs in the over 65 at a minimum cost of £150 per visit. So in the research that's been done about falls-related 999 visits, the minimum call-out cost in one area was £150 per visit. So it's incredibly costly. So if we accept, therefore, that despite the best risk reduction strategies, our clients will still fall or might still fall, we need to ask ourselves, I think, these questions. Do we consider, or do you consider post-fall intervention as much as fall prevention? So you consider fall prevention well, you put together a fantastic risk assessment, but do we consider the impact, the after effects of a fall when that person falls or if they fall in as much detail or give as much weight to it? And do we understand the implications of a fall and subsequent lie on health and well-being? And obviously those questions are linked. So they're questions to ask yourself as part of your own reflection. This slide is around, so if we don't consider the consequences of a fall and we don't put effective strategies in place, then these are the risks. So the physical risks are things like skin damage, hypothermia, dehydration, pneumonia, kidney failure through rhabdomyolysis. I hope I've said that right. But and the psychological effects are anxiety and reduced confidence. So these are things that we need to consider, that if we don't do our job and we don't think about what we do if somebody falls, this is the implication. So how do we avoid these post-fall consequences? It's all about providing the right care at the right time. So if it needs to happen at the right time, what is a timely post-fall intervention? To know the answer to that, we need to know and understand the two distinct timescales and labels identified as post-fall critical. And the first thing that we need to acknowledge is what a delayed initial recovery is. So delayed initial recovery is when the faller remains on the floor for between 10 to 59 minutes. The impact of a delayed initial recovery is psychological and emotional trauma, which increases post-fall anxiety and reduced functional independence or activity engagement. And there are research links within my references that will take you to where these came from. So if you've got questions about that, try the links and it'll show where the information is about that. But have a look at that time scale. So effectively, they use the term delayed to mean anything that's more than 10 minutes. So between 10 and 59 minutes, that doesn't give us an awful lot of time to get somebody safely off the floor so that we can limit the psychological or emotional trauma associated with that fall. The next stage is a long lie. So a long lie is when the faller remains on the floor for 60 minutes or more. So you go from delayed initial recovery to long lie. The impact of the long lie is an enhancement of those stated within delayed initial recovery, but with the additional physical and psychological elements. I worked in A&E and emergency services for 3 or 4 years, and I would often hear patients being handed over to nurse and staff or to ourselves as somebody who's had a fall with a long lie, with absolutely no description of actually how long they'd been on the floor. But anybody who'd lain on the floor, it was described as, or for any period of time really, was described as a long lie. But it makes me wonder whether if we were better with those definitions and had more understanding of them at that time, actually would we have been in a position to put better services in place to support those people, both physically and psychologically. Like psychology services, say, for example, if someone had delayed initial recovery, would we have been better placed with that knowledge to be able to use more psychological anxiety related interventions to help them with their recovery? I'm not sure. What a long lie leads to in particular, so we know that delayed initial recovery leads to anxiety and has a significant psychological impact. What a long lie can lead to is post-fall syndrome. Now, post-fall syndrome is a spiraling of fear, a huge increase in anxiety, which can lead to social isolation, occupational deprivation. So occupational deprivation, it would be people who disengage from meaningful tasks, so anything meaningful, any meaningful activity either within the home or socially, because of that fear. And it's a self-destructive cycle. So although you'll see that within delayed initial recovery, it's just enhanced by it being a long lie. And that's what that looks like. So you have a fall, you therefore have a fear of falling, which means you reduce your activity, so you become deconditioned, which increases the risk of falling, and you fall more frequently. It's that negative cycle, just based on the recovery not being there when you needed it. Occupational therapists, and like I say, other professionals, but I'm an occupational therapist, so I'm using our language, Occupational therapists recognise that it's vital clients are enabled to return to their everyday activities that they do as individuals in their families and within their communities, to occupy their time and bring meaning and purpose to their life. So if we know that a fall without a satisfactory and appropriate post-fall plan inhibits achieving this, then we need to ensure that the strategy is in place and pay even more attention to it than we currently are. And that's got to be based on your own service or individual reflection. So how do we actually do it? So post-fall risk reduction. So we've got to have a post-fall assessment, a risk assessment and intervention plan in place. We probably need to understand a bit more the role of the ambulance service. Certainly within care homes, it's fair to say that the role of the ambulance service isn't to come and pick a resident up off the floor if they're uninjured, and we'll come on to that a little bit. We need to understand the impact on the carers. So once somebody has fallen, whether it's carer or spouse acting in whatever role, what is the impact on them? Do they need a carer's assessment in their own right? Is it actually inhibiting their own engagement in meaningful activity? Is the carer becoming occupationally deprived because they're frightened to leave that person alone, who has their own fear of falling? But how do we determine whether it's safe to move somebody after a fall? So we're thinking about that post-fall risk assessment. iStumble is a really good tool. So this was originally devised by West Midlands Ambulance Service along with Mango and adopted by the Wales Ambulance Service. iStumble is a registered Mango international trademark, but it's a good demonstration of what can be included within any domestic or care environment to support safe transfer from the floor. Now, I'm not suggesting necessarily that the iStumble assessment is something that can just be cut and paste straight into a home-based, so a domestic-based risk assessment, but it shows you what you can do with a risk assessment to be proactive with that. You might need to change some of the language, but it shows what can be achieved. The other thing to be aware of is that the iStumble app, which has great guidance as well as this flowchart on it, is available from the usual download places, so whether it be Play Store or your iTunes store. It's great to have on your phone or device just to use as reference. One of the concerns that we often have from carers or care providers or families that we speak to when we're talking about post-fall risk assessment is something along the lines of, I'm worried that they've broken something, I'm worried they've broken a hip and don't want to move them. It is a really tough call for lots of people, and it's a very emotive time when somebody's had a fall. But the research shows that getting somebody off the floor in a timely manner, hip fracture or distal radius fracture or whatever that kind of fracture, hip fracture or not, supports better outcomes. So my advice is still get the person off the floor if it's safe to do so, following some sort of post-fall risk assessment and strategy that's put in place. What's absolutely imperative, though, is that when we're looking at a flowchart like that, is that the last box of the decision making is use correct lifting aids and manual handling to lift resident from the floor. So that will be resident or person if you were putting a risk assessment together. It's absolutely imperative that in moving someone from the floor, the right equipment is available. Doing that without the right equipment will be dangerous for the carer as well as the fallen person. So we need to be considering putting plans in place to manage post-fall risks, being aware that we now should have some understanding of delayed initial recovery and long lie and the impact that has on the negative cycle of falls. So once you've done this post-fall risk assessment, what we then need to be thinking about is what equipment do you put in place to manage that risk. Obviously, in some situations, you could be talking through a technique of standing, using the back of the chair and getting somebody to get into a sitting or standing position themselves. Obviously, if that's appropriate, then do so. But it isn't always, especially for somebody who falls regularly or is likely to be too frail or not have the muscular strength to be able to do that. So some examples of correct lifting aids or appropriate lifting aids that you can consider. So the elk, you can see there very clearly in that picture, and you've probably all seen before. Perfect to be used in a domestic environment. Great when it's folded up, can be stored away, really simple to use. The person can sit up on the floor, shuffle onto that when it's deflated, and then with somebody standing behind them can be inflated to get them up into a good high sitting position from which they can then stand. And that's a really good device to have in any setting, but is great size wise within domestic settings as well. The other example is the camel, so very similar to the elk, but with a backrest. So you don't necessarily need to have the person standing behind, but it does the same job. So somebody could have poorer core strength and be able to use this because they can lean back into the backrest. And you'll see, you've probably seen on the news quite a lot recently, actually, a lot of ambulance services taking up either the camel or the elk into their service because it's saving them an awful lot of time and an awful lot of hospital admissions. And there's a lot of research and case studies about that on the Manga website for you to have a look at. So I'd really encourage you to look at them. The differences would be the camel has a even though it looks like it is bigger, it has a smaller weight limit, and that's because of the backrest. So you can see that the elk has 70 stone and that has 50. The reality, though, is that that's the weight it takes. We all know within moving and handling and looking at moving and handling techniques that actually it's more about body shape. The chances of you getting somebody at 50 stone on there is very, very slim, but it shows that it's very, very sturdy. And if you've used them or had demonstrations of them, you'd be really surprised about how, even though they're air filled, how absolutely stable they are. So I've used them as examples and demonstrations of equipment that you can put in place to as part of that post-fall risk assessment and strategy. The other good thing about the camel is that you can, well, camel and the elk, but the camel, in my experience in particular, it's great for somebody to roll onto as you would apply a sling because it's slightly deeper. The goal of having those strategies in place is this. So we've looked at the negative cycle, the post-fall syndrome. The goal of putting the right strategies in place and considering post-fall risk assessment and strategy at the same time as we're putting in falls risk reduction strategies is that it increases confidence. So being able to get somebody off the floor within that 0 to 10 minutes, so there isn't a delayed initial recovery, increases confidence, helps the person engage in future physical activity, it improves strength and balance, it decreases the further risks of falls, so therefore there are less falls. So actually a good post-fall risk assessment and strategy is just part of your falls risk reduction. It's just that acceptance that somebody will or may still fall. It's what are you going to do about it afterwards? And I often get questions when we're doing this around the UK, when we were doing more physical presentations, is will my local authority or my NHS trust fund the elk or the camel for those patients? And the simple answer is absolutely yes. It's up to us to put the right case to them with the right statistics and the right evidence base. But what I'm saying is that all falls reduction strategy should come hand in hand with a post-fall strategy, because the two things go absolutely hand in hand. And there's no reason why, with a good risk assessment, a good pre-fall and post-fall risk assessment with the right equipment in place, that the delayed initial recovery and long lie can't be absolutely negated. So in the time that we've had, it's very difficult to go into great detail and depth about specific interventions that we would look to put in place to achieve what I've tried to give as a snapshot. I mean, we could do this as a 5-day training session probably, and do demonstrations and go through those bits of equipment together. In half an hour, 35 minutes, that's a real challenge, but I'm hoping that that's giving you some food for thought. And what we've done is said that work within fall should not focus on reduction, but on interventions post-fall as well. Sorry, not just focus on reduction, but on interventions post-fall as well. We've highlighted that fear of falling creates a self-fulfilling negative cycle. I think we probably already knew that, but it's about putting the detail into that. Do we know what negative cycle and how can we negate that risk? in my experience, people are often more afraid of the lie, and I've put long lie there because they're not always thinking about the first 10 minutes, but just afraid of being on the floor and left than the fall itself, in my experience anyway, within falls. Equipment is definitely available to mitigate that risk and support reduced anxiety, and therefore maximise occupational performance and engagement whilst minimising future risk of falls. The impact on carers cannot be underestimated. And just as a last thing there, I know these are really difficult times and we're using virtual technology a lot more, but I've done two falls, occupational therapy falls-based assessments in the last fortnight virtually. One on Skype and one on FaceTime, and actually they've been brilliant assessments. We've worked with great outcomes for those clients, and actually certainly for the first one, I think because I was paying even more attention to what I was seeing, the report itself maybe was even, and that's a reflection for myself, was maybe even more in depth than it would have been had I been doing it face to face, because I was desperate, because it was virtual, to not miss anything. I was able to get consent live on the recording. The recording itself is stored as per GDPR and ICO guidelines in the same way that any other bit of assessment would be conducted and stored in. And we were able to take snapshots from those assessments for me to include in the assessment documentation to highlight to those people what I was seeing and how to reduce the risk. So this is still something that can be done right now. And Manga are certainly open and raring to go to help you with putting the post-fall equipment in place. Some references there, so you're not necessarily going to look at them now, but when you get the presentation, there's some things for you to look at, and some links there that'll take you directly to where I'm getting my evidence from. So thank you very much for listening to that. Like I say, that's a bit of a snapshot. Hopefully you've been asking some great questions, and I'm sure you've got some great answers off my co-director Kate and the Manga team as we've been going. So now I'm going to hand over to Claire from Manga to do some live Q&A. So Claire, over to you.
Thank you, Adam, and thank you for the presentation. We've had some lovely comments, Adam, while you've been presenting about about your content and how interesting it's been. So thanks for those comments from everybody. Yeah, just a couple of questions that we'd like to follow up with for Kate and Andrew. I'll start with some for you, Kate. About the carer, really, and the risk to the carer if the expectation is that they should have to lift their loved one who's fallen, and how they should handle that.
I think the key when you're working with carers is giving them the confidence to lift, and that requires you really to have training in place. So if you're putting in a piece of equipment to lift, for example, the elk, it's a matter of trying that piece of equipment while the person hasn't fallen. So you're not going into a panic approach. You've tried it before, you've gone through it with a professional, you've actually tried it yourself, so you know how it feels. That will give the carer so much more confidence to actually lift somebody if they actually do go on to have a fall.
Thank you. Okay. We also heard from Adam a little bit about post-fall syndrome and the mental health issues maybe surrounding that. How do we manage client mental health with regard to post-fall syndrome with somebody who may be falling regularly?
I think for me, it's talking about fear. It's talking about their anxieties and trying to work out where the anxieties are happening and whether we can look at dealing with those anxieties in a different way. Talking is probably the best thing that we can do, but it's also saying to them, you're obviously very anxious. This is an area where you're falling. Can we look at some physical things that will support you not to fall again, and then not get into that cycle of that Adam talked about the fear factor and getting into that not wanting to do things because you're so anxious about falling. So I think it's talking to our clients, working out where they feel so anxious, and then trying to look at solutions to reduce that anxiety.
And I suppose, you know, Adam did touch on the fact that often when people fall that we are maybe looking at broken hips or other broken bones. And you know, I suppose it's just good to re-emphasise that point about the importance of lifting, even if someone has maybe broken a hip.
Yes, I think we all have this kind of anxiety about moving people off the floor and doing more harm. But as Adam has explained very clearly, the harm of leaving somebody on the floor is often worse than trying to get them back up again. And certainly, you know, in Wales, the ambulance service recommends that you use a camel or elk to get somebody off, even if there is an obvious break, because they don't want the ongoing other issues that come to the client if they go into a long lie. But I think it's also one of those things where if you know there's a break, get somebody up, but when you're speaking to the 999 caller, you explain to them very clearly that yes, they are safe, but there is an obvious sign of a fracture and you need an ambulance in a timely manner.
Thanks, Kate. And I think there's a question actually that leads on to Andrew from here on that basis, and that's about lifting somebody supine. Andrew, so if we needed to lift someone supine on the camel, can we do this?
Yeah, absolutely. The camel's been designed so that you can lift someone supine. You can actually lift someone supine both on the camel and the elk. On the camel, you just don't inflate the backrest. It's as simple as that, because on the backrest, you control it independently. So you control the backrest independently, adjust it to suit the person. But yes, you can lift people supine on both the elk and the camel.
Okay, and also leading on from another sort of point that we were making with Kate just now, which was about supporting family who may need to lift carers and maybe giving them some training. What is the situation on local authorities prescribing these sorts of products?
So local authorities absolutely prescribe the products, and for example, the camel and elk are really popular, particularly at the moment, to help get people out of hospital. So discharge from hospitals has been really popular. So we've been going in, we wear all the appropriate PPE, we go in and we do the assessment either in the hospital or in the person's home, and we run through either the elk or the camel, whichever is relevant. The camel, obviously we've had a few questions asking about, can you use the camel in someone's own home? Absolutely you can. In fact, only this week I've used the camel in a demonstration because the person was falling over in a tight space. So we showed them how you can use the camel in a tight space. We also showed you how you could use the elk or camel if the person fell outside. And actually one of the best demonstrations I went to was they're actually purchasing a elk so that he can go to his daughter's wedding confident that if he falls over, they can use the elk to pick him back up.
And that's great news, is people beginning to be able to sort of lead their lives normally if they've got the equipment that they feel confident about. OK, so I think we are actually coming towards the end of our time slot for this webinar, so I'll just hand back to Simon to close off the event. OK, thank you for that, Claire. I'd just like to say a huge thank you to start with to Adam for what was an excellent and informative presentation, and certainly one of the key things that stood out for me, Adam, was that post-fall management is equally as important as falls prevention. Both very important, but both need to be dealt with and managed appropriately. So that was really useful for me personally. So thank you for that. I'd also like to say thank you, Kate, for the support with the clinical questions. And we are going to be taking questions for the next couple of hours, and a summary of the Q&A will be sent out to everybody that has registered for the webinar this morning. We're also going to be sending you a post-fall management ebook. This is authored by the OT service, and it has various case studies in it, looking at falls in care homes, looking at sort of some collaborations with CCGs to support fallers. Okay, so that's pretty much it. I'd just like to say thank you for everyone for joining and listening to the webinar. Certainly any feedback is welcome. And if it's gone well for you, then please do join our future webinars, as we will be running a series of these over the next few weeks and months, particularly regarding falls. That's it from me. Thank you.